Our first speaker this morning is Michael McClung. Michael is the founding director of the Oregon Osteoporosis Center in Portland. He received his bachelor's degree at Rice. He was his medical degree at UT Southwestern. He was an intern and resident at Parkland, endocrine fellow at the NIH. He was founding director of the Endocrinology Clinic and the Bone and Mineral Clinic at OHSU, Oregon Health and Science University. He's associate editor of the Journal of Clinical Densitometry. He's on the editorial board of Bone and Osteoporosis International. He's got more than 150 peer-reviewed papers, 20 book chapters, more than 300 abstracts. And this morning he's going to give us a talk on the state of the art of osteoporosis.
Good morning, David. Thank you. I'm delighted to be back in Destin. I know it's not rheumatology on the beach anymore, but I'm delighted to be back in such a beautiful location. And so I thank you for inviting me to be a part of that. And I'm particularly delighted to share this morning's session with my good friend from a long time and close colleague, Nelson Watts. It will be fun for me to have the opportunity to share that with him. So my assignment was to talk about state-of-the-art of osteoporosis. There is a lot of art about osteoporosis. This is one of my favorite paintings by Salvatore Dali that's in the Dali Museum in St. Petersburg. I saw this in about 1988 or 89 for the first time, and I was a young person in osteoporosis, and the idea of having a crutch to support the back of a person with osteoporosis, that was what I was thinking about, struck me very vividly. Of course, remember in those years, we didn't have treatments for osteoporosis, and the patients in my osteoporosis clinic were mostly older women who had had one or more spine fractures, and much of our time was spent in support, both medical and psychosocial, of such patients with osteoporosis. Of course, there's also a lot of art in osteoporosis. If one looks at the various images that are derived from either histology or new imaging modalities, one can actually get off on the whole idea that bone is really a beautiful tissue, and some of the bone scientists have taught us with these images very much about what bone and bone metabolism is like. So with that as the teaser, let me disclose, as is outlined in the syllabus, that I have affiliations with all of the companies that have drugs on the market for osteoporosis and most of the companies that hope to have a drug in the future by virtue of having been a part of the clinical trials and being on their advisory boards. So the state of the art. I had to look this up to figure out what I was supposed to be focused on. It is the incorporation of new ideas and the most up-to-date knowledge in order to make advancements in already existing knowledge. Actually, that's a very pleasing thought. And the idea, especially for those of us who are as old as I am and who have had a 30-year career in medicine, can actually see that the state of the art has moved along quite dramatically over that interval of time, and to have observed the addition of new knowledge on top of existing knowledge. Often the existing knowledge is proven to be wrong, and we learn new things and new strategies and new approaches to things. And it's a process, of course, that is phenomenal if you sit back and think about it, and that somehow without any clear direction, this tends to go. And it's the collective input of lots of individuals, including, of course, basic scientists, clinical scientists, health policy planners, certainly clinicians, and even, of course, the patients have input into driving this whole circumstance. So let me address a few things and attempt to at least give you my opinion of the state of the art and where we are about things. Of course, the whole idea of osteoporosis as we currently know it derived in the 1920s, 30s, and early 40s, mostly driven by Fuller Albright, the father of metabolic bone disease, an endocrinologist in Boston, who was the first to actually do careful calcium balance studies in patients with osteoporosis, realized that postmenopausal women were in negative calcium balance and was the first to suggest that estrogen deficiency was somehow involved in changing bone metabolism in a way that led to calcium leaching from the skeleton, bone loss, and skeletal fragility. He mostly focused on vertebral fractures as the consequence and studied women with spinal osteoporosis in the main. We also already knew, of course, that hip fracture was a very important consequence, particularly very elderly people, and gradually the idea that osteoporosis was involved in both spine and hip fractures evolved during the 1940s, 1950s, and 1960s. Of course, then the whole definition of osteoporosis changed. Beginning in the late 1980s, it was defined not as an older person with a fracture, but rather as a systemic disorder that was characterized by impaired bone strength and an increased risk of fracture. That was a very important change in thinking, and it's often lost on people that that definition changed how we think of osteoporosis away from being the consequence of bone loss and skeletal fragility. So before this time, osteoporosis and fractures, especially of the spine and the hip, were synonymous. So osteoporosis was fractures. This definition moved the term osteoporosis away from the endpoint and redefined osteoporosis as a risk factor for fracture. That seems like a subtle nuance, but it turns out that it's really very important, and it has confused our field and some of our discussions and some of our thinking about the terms preventing osteoporosis. In the old days, preventing osteoporosis meant taking steps to reduce the risk of fracture. Now, of course, preventing osteoporosis means to prevent bone loss so that people don't have a low bone density. So the change in definition was important. Osteopenia was originally a word, probably the real meaning of the word osteopenia, of course, is too few bones. I'm not sure that this was ever applied to amputees as its main meaning, but the radiologists used the term osteopenia as the umbrella term to describe all bone diseases in which there was impaired mineralization. So osteoporosis was one of the osteopenias in the original days. And of course, beginning in the 90s, after the WHO criteria, diagnostic criteria based on BMD came out, osteopenia was redefined and is now thought of and understood as a T-score between -1 and -2.5. But you're all aware, as Nelson and others have taught us, that this terminology was never meant to be a clinical term, was introduced to be a term for epidemiological purposes, and really has very little clinical meaning. If someone comes and asks whether we should treat patients with osteopenia, it's an irrelevant question, because there are patients within the osteopenia category who are at very high risk, and treatment is obviously appropriate for them. And there are, on the other hand, many patients who fall into the osteopenia category who are at very low risk, for whom treatment isn't appropriate. And so the concept of osteopenia, or the term osteopenia as this category of bone density values, has never been useful, and we've moved away from that as one of the arts in medicine. We've come to understand osteoporosis not simply as a fracture, not simply as a bone density number, but as a process that over time results in bone loss and destruction or deterioration of the architecture and structure and strength of both trabecular bone. These beautiful images from David Dempster that were on the cover of the first issue of the Journal of Bone and Mineral Research was the images that helped me appreciate what osteoporosis was, and the idea that the strong trabecular network of trabecular bone was gradually dissolved away, destroyed, leaving puny, scrawny little trabeculae that were incapable of supporting mechanical loads, was an important advance forward in our image and our thinking of osteoporosis. Early in the field of osteoporosis, the term osteoporosis was coined back in the 18th century when a European pathologist noted in looking at cortical bone, that there were holes in the bone, and thus he coined the term osteoporosis. There's been a revival of